Good morning.
85 to 90%. But what is notable for a respiratory virus is this R naught or transmissibility. Now, let me tell you, nobody knows the true R naught of this virus, because what happens in an epidemic, the interventions you put in place all affect this. But it's pretty high. It's around 2.5, and certainly that's pretty high for a respiratory virus. So we need at least 60 to 80% to get herd immunity. We think we need that because no country really has achieved herd immunity as yet, and we don't know what weather is going to do in the northern hemisphere. So why are we so worried about COVID? Well, this is the reason.
Thank you so much, Ram, for setting the stage. I finally am on, so my apologies for the glitch, but thank you so much, Dr. Tandon and Dr. Nandkumar Jairam and Dr. Sudhir for setting it on. I do want to place on record our deep appreciation for Dr. Nandkumar Jairam's contribution to this entire exercise of creating the Global Indian Physician Initiative. Dr. Nandkumar Jairam is the CEO, Chairman and Group Medical Director of Columbia Asia Hospitals in India. He served as Chairman of NABH, Chairman of the Health Services Committee of FICCI. He was the Head of Surgery at St. John's Medical College and was also a member of the Board of Administration of St. John's. Currently, the Vice President of GAPIO, having been one of the founding members of GAPIO, and he graduated from Bangalore Medical College. Sudhir Bhai is a renowned specialist in allergy and immunology. He's been honored with the Padam Shri, the Knight of St. John's Knight of Malta, the Ellis Island Medal of Honor. In addition to his clinical work, he also heads Parik Worldwide Media, which is the #1 media house in the United States catering to the Indian and South Asian diaspora. He's a graduate from BJ Medical College, Ahmedabad, and is currently the Secretary General of GAPIO. I'm going to hand over now to Sudhir Bhai to introduce Dr. Anand. Over to you, Sudhir.
Thank you. Yeah, thank you, Anupam, for nice introduction. It's really a privilege and honor to introduce Dr. Anand Kumar. Dr. Anand Kumar is a professor of medicine, medical microbiology, and pharmacology at University of Manitoba. He is also Chief of Critical Care Medicine and Infectious Disease. He is also a researcher in the sepsis and other infectious diseases. And today he is going to talk about optimizing PPE. Let's welcome Dr. Anand Kumar. Dr. Anand Kumar.
Thank you. Let me just get the appropriate slides on board. There we go. Share screen, PowerPoint. And I believe you can see that now?
Yes, we can.
All right. Full screen now?
Yeah.
Yeah. Okay. I apologize. I'm going to talk to you about N95, which I think you call FFP2 decontamination and reuse. I'm not going to talk so much about PPE in particular. What I can tell you about PPE, as you just mentioned, is that basically the requirement right now is for enhanced droplet precautions, which basically means protecting your eyes either with goggles or a face mask. Of course, a regular surgical type mask doesn't require N95s in particular, and then gowns and gloves. You're all familiar with that. One of the major issues that's come up in North America and I think around the world has been the lack of sufficient N95 type masks, and so we've been doing a lot of work to see whether these can be reused. By the way, as to the person who spoke previously, I just wanted to add there is some data coming out of the Canadian National Microbiology Labs that demonstrates that SARS-CoV-2 actually can persist for a week to two on some of the surfaces around the hospital. So these are the kind of masks that I'm talking about. I don't know which of them that you have available in India in particular, but the 3M1860 is one example. 3M8210 is another example. These are a group, those by the way are molded masks, so they're kind of fit into a cup shape. And then there are these pleated masks that are made of a layered fabric kind of material, the 3M1804 V-Flex, the 3M1870 Aura, and also the AO Safety Pleats Plus. These are ones that we use. These ones can all be flattened. Basically, they can be put flat in a table. And that's important to know because of some stuff I'm going to show you in a little bit. So if you're going to be requiring processing, reuse, then there are a couple of things that you want. Ideally, you want a 6-log SARS-CoV-2 inactivation. That is, you want no growth at all post-processing. You want to maintain structural and functional integrity measured by fit testing and by some more advanced forms of testing. ASTM is American Society for, that should be MT, for materials testing. And that's a particle filtration assessment. And then you probably want to maintain this integrity for at least 3 to 5 cycles so you can reuse. Can I ask, are others, I assume others are having problems with having sufficient N95s around. Is that the case? Can you nod if that's the case? Yeah. All right, so we looked at a bunch of different methods that you may find useful. We looked at low temperature hydrogen peroxide plasma, also called STERAD, which I assume a lot of the hospitals in India have. We looked at vaporized hydrogen peroxide, that's a STERIS device. We looked at ethylene oxide, which is an older form of decontamination. Peracetic acid fogging, which is a more generic procedure, but works very well. Autoclaving we looked at. I figured that every hospital in the known world probably has an autoclave. A little bit of that at a relatively low temperature. We looked at pasteurization, 70 to 80 degrees Celsius for 1 to 3 hours, and we looked at UVC irradiation. This is the basic results that we have to date. Essentially, we used VSV, that's vesicular stomatitis virus, as a substitute for SARS-CoV in some cases. SARS-CoV can only be handled in a CL3 biocontainment facility. So if our biocontainment facility, which we have one in Winnipeg, had the appropriate equipment to do the decontamination, then we did it with SARS-CoV. But if our facility didn't and we had to go to the local hospital where I work, then we used VSV as a surrogate. It is also a single-strand RNA enveloped virus with similar structure and presumably similar inactivation characteristics. So what we found is autoclave completely eliminated the pathogen. Vaporized hydrogen peroxide, as in the STERIS machine, completely eliminated. Peracetic acid fogging, which I'm sure that is available all over the world, completely eliminated. Ethylene oxide, completely eliminated. Low temperature hydrogen gas peroxide, gas plasma, completely eliminated. UVC did not completely eliminate. No matter how high we went, it wouldn't eliminate it. And then there was always some residual, 1 to 2 logs worth. And then moist heat actually worked. I haven't put in the results yet, but it worked quite well. But you need a certain humidity, basically, is the key there. So we're still trying to fine tune that. Now, the other aspect of this is, can you then expose your mask to these decontamination techniques and still have appropriate function of the mask, both structural function and filtration efficiency? And what you find here, and this will be very interesting because I think it'll be relevant in a lot of places in the world that don't have some of the more advanced techniques, is that the molded masks, the ones that are shaped as a cup and they're of a different material, those would pass once. By the way, that's the 8210 and the 1860. So those would pass once, but then they would fail at anything more than 1, basically. But the pleated masks, on the other hand, the ones that are layered fabric, can be laid flat. All of those that we tested actually were good out to 10 passes. So you could cycle them 10 times. Ethylene oxide worked just great. Problem with ethylene oxide, of course, though, is that the cycle time is approximately 20 hours. So you can't get a lot done, whereas autoclaving, you can do a cycle every 45 minutes. Low temperature hydrogen peroxide gas plasma, I'm talking about the STERAD machines that you probably use for decontaminating instruments. We found that all of them would pass once, but when you got to your second pass, your second cycle, all but one failed at that point. All right, so we don't think that STERAD is a good option. There are some machines that have a lower intensity cycle and you might get 2 cycles out of it, but we're not using this. Vaporized hydrogen peroxide worked out to 10 cycles. Peracetic acid fogging, which is very easy to do, out to 10 cycles and still pass fit testing. UVC, as I mentioned, actually did very well in terms of passing the functional and structural integrity side, but didn't eliminate the pathogen completely. And moist heat, again, also well tolerated. At this amount, we had some small residual pathogen left, not a lot though, and probably okay to use, but we want to get complete elimination. What we think we'll have to do is go up to about 80 degrees Celsius and maybe increase the humidity up to about 40%. You can do this with if you have cabinets like blanket warming cabinets in the hospital. We have one on every floor. Those go up to this kind of temperature. If you put a basin of water in the bottom, you can get 22% humidity, and you'll get almost complete virus elimination after about 2 hours with masks that are put in there. As I said, we're going to have to try to push it up harder, which means that we're going to have to use a more active humidification process rather than passive with just a pan of water. We did also this ASMT testing, which is a form of testing filtration efficiency. The fit testing assesses both fit and filtration. So if there's a fail on that, you don't know which the problem is. This assesses only the filtration efficiency. And we actually found that all the techniques don't damage the filtration efficiency. That is, filtration efficiency remains intact. So the problem where we had fit failures earlier is actually related to the actual fit on the face. So conclusions. N95 mask decontamination is possible for reuse up to 3 to 5 times. VHP, peracetic acid, autoclaving, the latter for the pleated masks in particular, are all viable, but they have some disadvantages. UVC is possible, but what likely will leave residual virus, and lower temperature heating, pasteurization essentially, may be the most practical locally in North America. Autoclaving perhaps may be more practical internationally, but the lower temperature heating issue, the one with the cabinets, warming cabinets, needs some fine tuning. Thank you.
Dr. Sudhir, can you,
Yes.
I request you to introduce Dr. Leena now.
Okay. It's a real great pleasure and honor to introduce Dr. Leena Mendirata. She's a microbiologist and working as a senior consultant and infectious control officer at Apollo Hospital in India. She has been associated with the Apollo Hospital for last 20 years. Let's welcome Dr. Leena ji. She will be talking on RT-PCR overview. Dr. Leena.
Thank you for the kind words. Namaste, all of you. I'll just share the slides. Real-time PCR, obviously the preferred method for diagnosis, and the various commercial kits are there based upon the WHO protocol. Till date, the ICMR has in fact validated about 37 real-time PCR kits, and there are a few of them you can see here, some of the commercial ones. PCR, if you just look at it just for an overview, sounds quite simple though. There are primers which are specifically engineered genetic material. They're introduced, they bind to the isolated viral genetic material. Amplification is initiated. And this is what we read as positive, and if there's no amplification, we read it as negative. Sounds very simple, although it's not so. We'll just go on into it. It's actually this, for SARS-CoV testing, it actually involves the reverse transcriptase testing, so which is a little different from the usual one. It involves the complementary DNA followed by, sorry, yeah. So if we go on to the targets, my earlier speaker has made it easier. He's gone through the structural proteins of the SARS-CoV. And if you see here, the S gene is very important, as it codes for the receptor spike protein that enables the virus to infect the cells. So this is actually the spike protein which mediates the receptor binding, and it also determines the transmission capabilities. The real-time PCR assay, it's based upon the reverse transcriptase technology and mainly upon the two targets, that's a screening target and it's the confirmatory target. So the S gene, what we just discussed, that's taken as the confirmatory. It could also be the RDRP, which is translated as such into various commercial kits. And for screening, there is a target E gene, which actually corresponds to the overall beta coronavirus specific RNA. Once detected, it is actually indicating the presence of the detectable levels. If you detect both E and S or the RDRP, that is when you say it is positive. If it is negative, now that is when we say it is negative, but it actually may not be a true negative. When we say that, there may be actually be the level of RNA which is below the detection level of the assay in the patient sample. So again, this false negativity is something we really need to keep in mind. It really needs to be interpreted well. A negative result does not exclude the possibility with the infection. One needs to keep in mind there is a kit-to-kit variability. The sensitivity and specificity may vary. As they say, there's about a 60% sensitivity for the RT-PCR. Again, there's a limit of detection for every test available for every kit. It may vary. Many variables: what is the best specimen type, what is the collection method, what is the testing platform on which the RT-PCR was performed, again, what is the time of collection. So if you just see the preferred specimen is definitely the lower respiratory specimen, the BAL or the tracheal aspirate. But again, there is a risk of aerosol generation with this. So generally the upper respiratory specimens are either the throat swab, nasopharyngeal, oropharyngeal, or it could be the washes or the nasal aspirates. Again, one needs to keep in mind what swabs is one using, because cotton swab or maybe a wooden shafted swab may just inhibit the reaction. So one has to use something like Dacron or polyester flock swabs for it. Sputum these days, much debate and active research is going on the value of using saliva or maybe sputum actually as a specimen, and more emphasis has been given on self-collected swabs now, which decreases the exposure of the healthcare worker collecting the specimen. In fact, what is really a good specimen type? The data on the best specimen type is sparse. When to collect? Again, a lot of debate about it. Within 3 days of symptom onset, that's what is said, maybe extending till 5 days. Again, it's seen that if it's later than 7 days, the yield definitely decreases and it may give rise to something like a false negative again. Something like even antimicrobial chemoprophylaxis, maybe even HIV therapy, it has a role to play in this. The storage is again important. If we haven't stored the specimen properly, or if there is a delay in testing or shipping, we haven't stored it properly, it may again, just give a wrong result on us. Transport, of course, for better biosafety precautions. So one has to avoid a false positive, so well known with all PCRs, maintain good biosafety practices, and follow a unidirectional workflow. There has to be a proper segregation of work practices. Physically separate areas have to be there for an extraction, for the amplification, and the final loading on into the instrument. The person in performing the RT-PCR has to be wearing proper PPE. There has to be proper ventilation requirements in that entire lab area. At the end of the day, good biosafety practices, yes, even more so while performing this kind of test. So if at a later date and the suspicion of COVID-19 is strong, it calls for a fresh sample collection, which is generally taken as a gap of 2 to 4 days after collection of the first sample. And definitely this needs to be kept in mind if clinically or radiologically the suspicion is strong. Again, sometimes, which is a limitation, either of the genes cannot be determined or it may give some indeterminate result. Further testing may be required using another kit with a different primer and a probe. So COVID-19 is an emerging, rapidly evolving situation, and every day we are learning more and more. Thank you.
Thank you very much, Dr. Leena. Thank you very much. And we thank Dr. Sudhir Parekh also to moderate this session. And I think still the audio system of Dr. Anupam Sibal is not working. So let me now introduce and invite Dr. Bodiwala from UK and request him to moderate this session. Dr. Bodiwala is a acknowledged and one of the pioneers and experts in the field of emergency medicine nationally and internationally. He remained head of the emergency department in Leicester, England for 26 years. He is honorary doctorate of University of Leicester and De Montfort University. He was awarded Commander of the British Empire, highest of the four, by Her Majesty the Queen, first to an emergency medicine consultant. The emergency department in Leicester is named after him as Gautam Bodiwala Emergency Department, the only in the UK. The International Federation for Emergency Medicine has created its highest award, Gautam Bodiwala Lifetime Leadership Achievement Award, to mark his contribution internationally and founding of the International Federation. Dr. Bodiwala has received 9 fellowships of Royal Medical College and honorary membership of emergency organization. Dr. Bodiwala has published over 70 research papers and 1 book. May I invite Dr. Gautam Bodiwala to introduce the next speaker, please?
Dr. Deepta.
Yes.
Thank you, Anil, for that very kind introduction. It's a great pleasure to introduce Dr. Deepta, who is a board-certified internal medicine and infectious diseases and a fellow of the American College of Physicians. She has got a long-standing clinical career. She was the director of Comprehensive Center for AIDS, Hepatitis C, Infectious Disease, Infection Control at St. Vincent Medical Center, USA. She was Associate Professor of New York Medical College, past President of American Tamil Medical Association of USA. She is known for her passion to teach and mentor young physicians. It's my great pleasure to invite Dr. Deepta to talk on serology, please.
Hello, can you hear me?
Yes, we can.
Yes. Dr. Ramkumar has my slides. If you could project the slides, I'd appreciate that.
Dr. Tandon, can we make sure that Dr. Anand can put Deepta's slides on?
Yeah, sir. He had the slides and he said that he will project on behalf of Dr. Deepta.
Okay, while we are waiting, let me talk. Welcome everybody. I am calling from USA, and it's a great privilege to be part of this distinguished panel. My task today is to talk about the serology for COVID-19 disease. And among the testing, RT-PCR, which was described with the previous, you can go to the next slide, Dr. Next one. Thank you. And we have come a little late in the game for the serology testing for the SARS-CoV-2. Can you go to the previous one?
Sorry, there's a bit of a delay, I think.
Okay. Anyway, let me keep talking about this. The serology testing for SARS-CoV-2 is not any different than our original serology. Serology is fundamentally used to diagnose disease either in the acute stage or in the later stages, compare the antibodies to make a diagnosis, or in the further later on stages in convalescent periods to see what is the neutralizing antibodies. And as you can see in this picture, the antibody response can be multiple. It can be IgG, IgM, IgA, which is also secreted in the epithelium of respiratory tract as well as GI tract, and of course IgE, which usually contributes to the allergic reaction, histamine-related reaction. And the primarily protective ones are the IgG and the IgA. IgM initially is formed on the recognition of the antigen exposure with the B cell activity, and then this IgM later on continues to recognize it and then prods on to get the IgG antibody. As you can see on the picture, the IgMs are the ones which are primarily involved in blocking the receptor cells, the receptor of the cells in which the virus gets attached. In COVID-2, in COVID-19, the receptors are primarily in the respiratory epithelium. Of course, now we also realize that it has other activity like gastrointestinal and diarrhea, which may be side effect or the effect of the virus, either with the receptor or otherwise as a part of the cytokine reaction, which happens with the infection. When you have saturated the multiple receptors, then the infectivity does not happen. The rest of the IgG is used in phagocytosis and then stimulation of the B cells and then to macrophages, and as well as cytokine reaction from the T cells. And those are the ones which help with the immunity. And of course, overactive cytokine is also a big issue. So if you look on the lower portion of the graph, you can see on the first exposure, within a matter of few days, within 3 to 5 days, you start getting, that is the first initial reaction is the IgM. And then that is the IgM goes on till about 7 days, maybe up to 10 days in these patients. And I have another graph to show you after that. And then after the first response with IgM, then if you have continued infection and of the cells, then you have an enormous production of the virus. With that, you have then IgG surge come up. And the IgG is the one which is usually the neutralizing antibody. And the neutralizing antibody is the definite method of getting rid of the viruses. And the issues, you can go to the next one. The issues are with the antibody testings are, as I said, it is probably at this point cannot be used as a diagnostic test in the initial phase of the antibody. And can I have the next slide if you don't mind?
I'm trying.
Okay, thank you very much.
No problem.
Okay. The issues with this antibody testing at this point are, at this time, the diagnosis cannot be made of an acute infection with antibody testing. It is still preliminary. Multiple testing has been approved on an emergency basis in the market. And when you approve them on an emergency basis, that means the validity and the specificity and sensitivity has not been done. Many of the antibody testing has been looked at. One area, if it's available, in a commercial setting and widely available, we might think about using it as a testing in the early phase, where you can up the IgM and the IgG together. The IgM starts coming on by the 7th day. IgG starts coming on by the 14th day. So there is a phase, a window period from 7 to 10, 11 days where you have sometimes lower viral load, but this phase can be used for detection of the antibodies, either IgM or IgG. Most of the tests which are all coming in at this point are a combination of IgG and IgM, so that they can pick up this testing. And as you can see from the second slide, the asymptomatic phase where the virus is really very high at the point, and all of the testings have been negative. The PCR is also negative at that point. And as you can see, antibody testing is also negative. So there's a lag period in picking up any kind of laboratory diagnosis of COVID-19. And this is the area where we are really worried about because of the high viral load transmission of the disease. These are the reasons why United States, even though a little later on, agreed with the with masking of all the individuals, which has been practiced in other places to prevent the transmission from respiratory droplets as well as from saliva. And the IgM immunity starts on and wanes off quite rapidly, as it's usually suggested. It does not last beyond 28 days. And whereas IgG, as you can see, it starts on the 14th day and continues on further. And at this point, we do have testing to show that IgG is present about 48 days, and then probably further levels off at a particular late rate. So these testing can be used as testing for diagnosis in people who have been exposed and has been quarantined, and you can make them come back in at a later time to get them tested. Usually, if they are symptomatic, we prefer them to come back 3 to 5 days after the symptoms have started. That will be the best period to get tested. Of course, if they have pneumonia, and that means that there is already cytokine reaction and there is respiratory inflammation available, PCR will be the ideal thing to do at that time, because antibody testing is only theoretical at that point. Antibody testing at this point should be done primarily to detect either some exposed or as past infection. And there is, as any other testing, there's false positivity and the false negative antibody testing also. And what are the other areas antibody testing can be used? If we can find the level of immunity, that is in which a person recovers from COVID-19, that will be useful. At this point, there is no antibody level definitely known as when they recover from. That again, as we start testing patients who are recovered from COVID-19, also serial testing of patients where we have had banked sera, and to correlate it with their clinical conditions. If we look at them serially, we would know the height of the antibody and then the curve, and when is the protective neutralizing antibody appears. What is the necessity to know that antibody level for neutralizing is because that is how you decide on the vaccine for vaccine efficacy. And for a vaccine to be efficacious, you need to have that amount of antibody, or probably a little more over that, to make sure a person does not get COVID-19 after immunization. And also, it also gives you the duration of the vaccine. We can continue to monitor the levels of the antibody, IgG antibody, to see when does the antibody level wanes, and this will give us about the duration. At this point, there's discussion that the vaccine may be only for 2 years, 3 years, but many other vaccines give right antibody. And the antibody response in vaccines is memory from memory T cells. So when the virus is exposed to a certain person who has recovered from COVID-19, it is presumed that the virus will stimulate the T cell memory cells, and which will again will recognize the antigen and will produce the antibody, and those are the neutralizing antibodies. At this point, it is presumed that with the limited reinfection, that IgG antibody developed after a person recovers from COVID-19 may be protective. Again, needs to be confirmed. There have been some cases where patients have had relapse of infection or reinfection. Again, not confirmed yet. It could be a cytokine resurgence, or it could be the virus. These all of them needs to be. And one of the ways we could use these tests is some of the antigen antibody complex on the earlier period. The reason why the antigen antibody complex in COVID-19 may not work with serum is the antigen level or the virus level in the blood is quite low, in contrast to HIV and hepatitis C and other virus and hepatitis B, where there are very high levels of viruses in the blood. And you could do an antibody testing as an outpatient testing. The combination testing is being done for these things. Unfortunately for COVID-19, the antigen antibody testing in the blood is one which may not be able to avail. We can only probably do the antibody testing, and the antigen testing, of course, has to be done in respiratory with a PCR with respiratory mucus area. Somebody has mentioned about other areas also. Same way, we could probably can look for antibody testing in the stools and saliva and other areas. If they are all done, if they are positive, then maybe they are easier way to detect antibody and easier way to detect COVID-19 diseases, which will be used in epidemiological purposes. And the issues with any antibody testing is false positive and false negative. Can I have the next slide, please? All the antibodies testing tells you is the serology which is present on the level of antibody, but it does not mean that somebody is immune to COVID-19. As I said, we are still struggling with that particular area, and probably looking at in some of the material which is coming from China and maybe from Italy as well as the United States, since we've had the disease over a period of time. And we could probably look back and see what is the level and when can we declare somebody immune. And any serologic test, as I said, has to be validated with the other testing and multiple testing. And we are still waiting for it. Quite a few serological testings which have been coming has not been as good as we thought initially. And if I'm not mistaken, the Abbott serology in some of the hospitals had about 20% of false negative tests, and it again need to be validated further. And all the serological tests, it says somebody has a past infection. They can be either asymptomatic or they can be recovered in that area. False positive results occur in many of these tests because of cross-reactivity. People could have been reacted to some of the coronaviruses before, or other viral reactivity. False positive results in SARS-CoV-2 mainly causes difficulty with isolating the person unnecessarily, and also missing the diagnosis of other bacterial diseases and other treatable infections, and unnecessary use of protection in these patients, and unnecessary use of medications like hydroxychloroquine or azithromycin, and all of the issues. So the specificity and sensitivity is very important. Next slide, please. False negative test is even worse. False negative test gives us which tells you that the patient, what it means is a patient may be exposed to COVID-19, but our test is not picking up the antibody levels. It may be too early, or antibody level might have waned off and we may not be able to pick it up. This is really one of the difficult areas because false negative test gives us a sense of confidence, and we release the people without any kind of infection control. So they may become they are asymptomatic and may be the further vector for spreading the diseases. And if a person is symptomatic with any of the COVID-19 symptoms, headache, muscle pains, diarrhea, cough, pneumonia, and the test is negative, the ideal way is to confirm it with the PCR testing before we say that somebody is negative. And if we further think that they have COVID-19 disease, continue to isolate the patients and bring them, advise them to come back in 3 to 5 days and retest them both with an antigen testing at that time, which will be the confirmatory testing. And these are the issues with antigen antibody testing. There are multiple testing which are available. There are also testing which can be done at any site, with rapid testing like the pregnancy testing which are used. The testings which I talked about are usually ELISA. There is also immunofluorescence testing and other chromatographic testings which are available. The ones which we would like to have is the one similar to what is being done with HIV testing, which is done at the point, right at the emergency room or the doctor's offices, which only need about 5 to 10 minutes with a quick of his blood, and then in a strip, and then adding a reactive agent and waiting for about 5 to 10 minutes, and then you get a test results back right then and there. And then with the clinical symptoms, you make an assessment of the patient, and either they are positive or negative, or if they're suspicious, continue to follow them and make them come back at a later time to follow them. With that, I'm going to stop that discussion, because I'm going to be continuing with the same one in the next topic also, which is the pool testing. Now, Dr. Sudhir, or would you like to reintroduce me? I don't see a reason for it, but I can continue with the pool testing.
Dr. Bodhiwala. Dr.
Oh, yes.
Deepika is the next speaker on the topic pool testing. So I think let us request her without reintroducing her. Dr.
No,
Bodhiwala?
carry on requesting, but I would simply request that it will be great if you could stick to your time, because
sure,
there are so many speakers.
Oh, I'm sorry.
On.
I would like to give a prompt if I went over the time, because
well, I a couple of times raised my hand, but probably you didn't see that.
Okay, I will look for
what is the time per speaker, Anil?
It is 5 minutes, sir.
So I would be grateful, Deepta, if you stick to your time, please.
Absolutely, I will do that. Thank you. And the next slide is on pool testing.
You went on for nearly 15 minutes.
Oh, I am so sorry. I will just do 2 lines on pool testing then. Pool testing is a antibody testing as well as antigen testing in a pooled manner. The primary reason is for epidemiological purposes, and pool testing can be very well done on both frozen sera as well as the sera which is available. As the name, you take whole bunch of sera and you test them all, like 100 sera at the same time. So the test kits are used, much less test kits are used. So one test kit is used with 100 sera, sample of them. And then if one of them is positive in the groups of first batch, second batch, third batch, you pick up the batch and then you go further down. You can do it through zip code, you can do it through the hospital, you can do it through age. So multiple variants can be done with pool testing. Pool testing is now done in Sanford, initially to show they only had very little of infection. Of course, all of you are aware of the pool testing in New York City, which is done for antibody testing, which shows that there's anywhere between 8 to 20% of pool antibody present in the New York City. And pool testing is also good for herd immunity. So this is the way to go further on. This will minimize the cost of testing, and it will also give us an understanding of how many people are infected in the society, which will be useful to release the lockdown or to the infection control procedures. And later on, it will also give us the immunity from vaccine. With that, I'm going to stop. Thank you.
Thank you. My apologies, Dipta, for
No problem.
Reminding you about the time. But
Absolutely,
many thanks
no
for
problem.
two interesting talks. Now I'm going to introduce Dr. Suvarna Chakravarti, a fellow countryman, adopted countryman. Suvarna is a fellow of the Royal College of Pathologists and member of the Royal College of Pediatrics and Child Health. She's a consultant pediatric hematologist at King's College Hospital in London, United Kingdom. She's a very highly regarded academician and a clinician with over 82 research publications in very reputed journals. I'm going to ask Suvarna to come and give a talk on newer tests. Thank you, Suvarna.
Thank you very much for your very kind introduction. I feel I'm a little bit maybe not the great expert here in COVID testing, but I would, given that I'm a hematologist, but I do understand a little bit of laboratory medicine, as it were. I was asked by the Dr. Sibal and the organizers to talk about basically horizon scanning. So not what's being done at the moment, but what sort of testing might be done in the future. Now, before we start on that, just to give you a perspective, just for 1 minute on the UK testing policy, which, as you all know, we have the dubious honor of having one of the largest COVID-related deaths in Europe and arguably the world. And so, you know, it cannot be understated how important it is to have a policy which would match the science. And I suspect we have been a bit unfortunate that quite hasn't matched in the UK as we would like it to be. So in early February, March, just as the COVID pandemic was announced, our testing policy simply was to test the very ill patients within hospital, not in care homes or nursing homes, but only in hospital. So the mildly affected patients in hospital were not tested. This then got changed, and then healthcare workers who were becoming increasingly symptomatic then started getting tested. And then subsequently the policy changed again, and sort of catching up business of other essential workers out in the community and their families. Finally, now testing has expanded to symptomatic and over 65-year-of-age people in care homes or in their own homes, which wasn't happening in the past, or people who might have to go to work and leave their households. So this has been for people who are in the business of treating and getting affected by COVID, this has been a very hair-raising experience where policy is really behind, lagging behind science. So I'll give you some cutting-edge technology now. So this is basically something that, sorry, excuse me, I'm just going to have to plug my computer. So this is something which gives you very rapid antigen testing. This is a nucleic acid testing. So we're on the realms of antigen testing at the moment. So this gives you an RNA testing, but unlike what's been described before in the PCR technologies, the RT-PCR, quantitative PCR testing, which takes sophisticated machinery, takes quite a long time. This was recently published where you can basically use a very crude form of RT-PCR, but actually use just a simple thermal cycler, which will only give you, it can be used, you can use it in a clinic setting where you only really need 63 degrees centigrade for 40 minutes. So you can get a color change, and that might be able to be used sort of in distant places where technology might be difficult to get to. So this is not something that's being used at the moment, but something that can be used particularly in low resource settings. There are some more cutting edge stuff that's coming through. The CRISPR-Cas9 world of scientific advancement has not been lazy during this COVID pandemic. So they've been using quite a lot of Cas based technologies to provide very quick turnaround nucleic acid testing. As you know, Jennifer Doudna is this very famous scientist who discovered the CRISPR-Cas9 gene editing technology. And her group has also come up with another testing using that kind of gene editing technology to have a rapid RNA-based technique detection in about 30 minutes. There are lots of other labs out there who are really killing themselves trying to develop these things, which hopefully can be upscaled, can be made more widely available, and quick, rapid turnaround testing with good sensitivity and specificity. As I said, these techniques are not currently in use. Now, the other thing to think about is source of sampling. This has been previously touched up before. At the moment, obviously nasopharyngeal, because there is a little bit of time lag between the infection getting into the nasopharynx and finding its way into the lungs, it is a good thing that nasopharyngeal swabs can be used, but it's a bad thing that during the time that nasopharynx is infected, the patients remain relatively asymptomatic. So nasopharyngeal swabbing is currently the standard, but now lots of work is being done to understand how deep cell swabbing of saliva, spitting into a bottle, sampling directly from the salivary gland can be used for more specific testing. Bronchoalveolar lavage, of course, can be used at a later stage of the disease when patients are particularly much more affected in their lungs. Viremia consistently has been a poor, also a blood detection of antigen has been poor in this condition, as we all know. But there's new data coming through for the last few weeks to show that rectal and anal swabs can predict, can isolate, you can identify RNA virus SARS-CoV-2 on these swabs, and sometimes there's persistent viral shedding even weeks after the initial nasopharyngeal swab being positive. A few more cutting edge technology here, where I'm still under the theme of antigen testing, so testing the actual RNA. And this is where nanotechnology comes into play. This is what you can see. I don't know if you can see my pointer, but this is a graphene material which is used in a kind of a transistor type thing, which I don't quite understand the science of it, but essentially this is a nanotechnology platform where antibodies are embedded onto that graphene sheet, and then you can just simply take a swab from a COVID-19 patient, put it into a viral transport medium, stick that these virus containing transport medium onto that graphene sheet, and something brilliant happens, and a readout happens in a matter of minutes. So this is again antigen testing, but it can be very, very rapid. It uses antibody immunological fixing technology, but it doesn't actually test the immunity of the patient. It tests the actual presence of the antigen in the or the virus in the patient. Now on to some antibody testing. Now that's been done quite extensively by the previous speaker, but this is something in the horizon. This is where you can do quite quick testing of the antibodies that can be present. So again, just it's called a lateral flow immunoassay, and this again using nanoparticles, using technology where the antibody in the patient can then be fixated using these nanoparticles, and then you can then.
Will she say something?
Sorry, is there? Okay, I'm nearly done. And then you can finally get a readout from an anti-goat rabbit and IgG. So this is, again, as you can see, it's a 10-minute test, a very quick turnaround test, a point-of-care testing for immunological testing for SARS-CoV-2. So the challenges of immunological testing. So previously already mentioned, but we don't really know what we are testing other than the fact that somebody has had an infection. We really do not know where we are in terms of antibody levels. We don't know whether the titers are protective, at what levels of what sort of titers are these antibody, are these neutralizing antibodies actually protective? There are some about quite staggering numbers, up to 20% of patients who may not actually have measurable antibodies, even if they've got RNA positivity in their swabs. What does that mean? And as I said, we don't really know the correlation between the antibody titers to immune response. We don't know how the antibody titers may or may not be related to cellular immunity, and how do you study cellular immunity in these settings, we don't know. And how can these technologies be scalable? How long do these neutralizing antibodies persist? What about reinfection? Are we, once we've got the infection, can we be protected for at least one season like influenza? We don't know. So population-based seroprevalence data is currently being collected in many countries, including the United Kingdom, just to give us an idea of what sort of spread there has been. And for that, the immunological testing has been very helpful. And the one final slide about digital technologies. So other than actual testing, there are some digital technologies that can be used to monitor and measure this pandemic. So things like the Internet of Things, which are using 5G mobile technology, big data, artificial intelligence, digital platforms such as social media, and another very everyday thing that we're already doing in our lives, virtual clinics, AI-based symptom triage, and so on. And with that, I will stop. Thank you for your attention.
Thank you so much, Subarna. That was brilliant, and it's so exciting to see that all the body of evidence that we have, whatever little we have, has emerged in 100 days. And I was looking at some of your papers, and they're like 3 days old. So really very up to date. Thanks ever so much. And over to Dr. Gautam Bodiwala, please, for the next session.
Who has got a special interest in abdominal imaging. Dr. Raju has done his postgraduate training in Hyderabad and also in Leeds in England. He has got a substantial experience in clinical leadership, having held many senior positions of responsibility in United Kingdom. He's actively involved in teleradiology and artificial intelligence. Dr. Raju is the CEO and Medical Director of Apollo Radiology International. May I invite Dr. Raju to speak on role of CT scans. Thank you, Raju.
Thank you, Dr. Gautam. That's a great introduction, and thank you, Anupam, for giving this opportunity. Can I just check that you're able to hear me well?
Yeah, we can hear and see you.
Excellent, excellent.
And your slides.
Thank you. Right, this is not strictly a laboratory-related topic. Obviously, it's radiology, and as Dr. Gautam said, I'm an abdominal radiologist, so I'm not a chest radiologist. But again, it's what we are talking now is not really depths of radiology. We're talking about the strategy and policy of how we should be using CT scan in the diagnosis of COVID-19 infection. Now, as expected, in a new disease that is spreading extremely fast, there has been a lot of confusion initially on how to use CT. Data from China has shown a very high degree of sensitivity, almost 95%, far superior than PCR. And China has used CT elaborately during the initial couple of months of this epidemic. But then subsequent papers from the West have not shown that kind of performance by CT scan. And it has been identified as one of the main source of hospital-based transmission. So the use of CT has been scaled back substantially in the last month or so. Now, a consensus is beginning to emerge. So the first such statement comes from the Fleischner Society. It's a multinational consensus statement. And it's essentially, it is threefold. It says the imaging is not indicated in patients with suspected COVID who have mild clinical features unless there is a risk of disease progression. Imaging is indicated in patients with COVID-19 and who have a worsening respiratory status. In a resource-constrained environment, which I think would be of interest to India, where either the PCR capacity is limited or the cases outstrip the supply, imaging is indicated and can be used in triage. So when we do that, we only do that in patients with a high clinical suspicion, high pretest probability, and a moderate to severe clinical illness. So in this case, you're supposed to use chest X-ray to start with, ideally a portable chest X-ray. And depending on the chest X-ray findings, if it is normal or equivocal on the background of high index of suspicion, then you do CT. So there are a lot of pathways out there, and each organization is trying to develop its own. What I'm showing here is a Basildon protocol, And as we discussed, if the patient who is suspected with COVID has a mild illness, then you don't do any imaging at all. If the pretest probability is high and if the illness is moderate or severe, you do chest X-ray along with the PCR. And if the chest X-ray is typical for COVID, you don't need to do a chest CT, and the patient is treated as COVID infection. If the chest X-ray is normal or equivocal on the background of moderate illness, then you proceed to do chest CT. And depending on the findings of CT, you can then classify the patient into a low probability, intermediate probability, or high probability of COVID, regardless of whether the PCR is positive or negative. So some organizations are advising CT immediately after the negative PCR in cases of high index of suspicion. And so that is kind of used as a step 2 after the PCR and chest X-ray. Both are normal or equivocal on the background of high suspicion, then you do a chest CT. Now, you probably have heard about the patterns of the coronavirus infection on chest CTs. The main findings are lower lobe dominant peripheral multiple foci of ground glass opacities. This may be associated with crazy paving, peripheral consolidation, air bronchograms, and a perilobular pattern. So if you have these classic findings, then the diagnosis is almost 100% certain. You can have very few ground glass opacities and then have the consolidations and a perilobular pattern, which is a probable. And then there is a good number of indeterminate cases where you don't see these findings, and then you base your decision on the clinical context. This is just an example of a case of COVID-19 infection. As you can see, there are bilateral lower lobe, multiple peripheral ground glass opacities, a classic case of COVID-19. Finally, AI. Sorry, it's been a very brief presentation. I've been told it's 5 minutes, so I've not really given, not going into much of a depth. So AI has been used and is being used in multiple centers. And we got both chest X-ray algorithms and chest CT algorithms. The vendors of the chest X-ray AI claim that the performance of the models is on par or superior to human interpretation in picking up the findings of COVID and making a very quick 20-second diagnosis. And there are multiple vendors that are doing that. Chest CT, you've got 2 types of models. There are models that diagnose the infection, and there are models that quantify. The one on this slide is from a company called Zebra Medical Vision in Israel. And this is essentially quantification model that kind of estimates the percentage of lung that is involved so that you can follow up and assess for progression or regression. I think that's it from me, very, very short, but I wanted to stick to the 5-minute time plan.
Thank you. Thank you so much, Raju. That was very helpful. And thank you so much. So well, and now as we have finished the formal lectures, we are now going to move on to the Q&A. And for the Q&A, I have 2 distinguished colleagues, Dr. Suresh Reddy, who's a neurointerventional radiologist based in Illinois. He's a product of the Kakatiya Medical College, and he is the current president of the American Association of Physicians of Indian Origin, and 36th president at that. And we also have Dr. Anupama Gotikamula, who's a pediatric anesthesiologist in Texas. She's again a graduate of the Kakatiya Medical College, and she is the vice president of the American Association of Physicians of Indian Origin. And a couple of years from now, she's going to be the president. But before I request Anupama and Suresh to do the Q&A, I have great pleasure in welcoming Dr. Pallu Malawala, who is the president of the Australian Indian Medical Graduate Association. She's present along with her executive committee. I want to thank her for her presence, for joining. And as we know, it's past midnight in Australia. So really appreciate your coming in, and would request Dr. Pallu to say a few words. Can we please unmute Dr. Pallu?
Can you hear me?
Yes, yes. Thank you so much.
Hi. Hi. Thank you everyone for having me here. Yes, it's nearly 1 o'clock in the night, so look, it's a very informative evening, and I'm very, very happy that I joined you people today. Australia has done really, really well in controlling the coronavirus. Um, we don't know whether we are going to have a second wave or not, but just today we heard that there were only 2 new cases in New South Wales. So yes, but we still wear the masks and we still do everything right, and we still keep the social distancing. So hopefully everything should go right in Australia. Thanks so much for letting me talk.
Thank you so much. And we seek active participation from colleagues in Australia. And thank you so much for joining. And now over to Dr. Suresh Reddy and Dr. Anupama, please, for the Q&A.
Thank you, Anupam, and good morning, good evening to all. And we have a few questions, so we'll wrap up very quickly. We don't want to waste much time, and I request all the speakers be unmuted now. And I'll forward the question to the specific speaker, and then you can answer the question. So the first question is to Dr. Anand. He's unmuted.
We're doing
so
that.
The question. Yeah, the questions are on the PPE. So how effective when people don't use masks while talking? Can N95 be used after keeping in sunlight?
So let me answer the second one first. If you expose the mask to sunlight or just leave it out long enough, you will substantially decrease the viral counts. We've been doing some work at the National Micro Lab in Winnipeg, where we've been putting virus on different surfaces that are seen around the hospital. And what we find is that different surfaces retain the virus for different periods of time. On cotton, it'll disappear within 24 hours, undetectable. But on some of the plastics and some of the other material, we've gone out to a week or longer. So in fact, we're up to testing it 2 weeks now. So if you take it and you put it in sunlight, it will definitely decrease the burden. And after about a week or so, I would think that it would be quite low, but there's probably some left.
All right, thank you. So we suggest to have 5 or 7 masks and put them in the sunlight after every use. I think that'll take care. The next question will be from Suresh Reddy.
Hi, this is Dr. Suresh Reddy from Chicago. My question is, this is question from the audience. This question is to Dr. Deepta. Certain commercial kits do not meet sensitivity requirements. What are your comments?
Yes, I think this is one of the areas we have a problem with because of the emergency authorization. Normally, a test is developed over 1 or 2 years, and we will be doing testing with other material to see the sensitivity and specificity. Unfortunately, we are at this stage. So as I said, if you lack either the sensitivity or specificity, you have to use your clinical judgment, and then according to your clinical judgment, bring in the person again or start teaching them and do other testing like PCR testing or a chest x-ray or a CT scan to confirm your diagnosis. This will refine as we go on because there are a lot more platforms are coming on.
Thank you, Dr. Deepta. Back to you, Anupama.
So Deepta, this is another question for you. Any relapse of infection once you are IgG positive, and so is there any comment on that?
We at this point do not have any confirmed relapses. We are waiting to get information from some of the cases reported from both in USA as well as in China. We need to do all the antibody testing to show that it's a relapse. Relapse means the antibody testing should have come down, and then another infection and the relapse goes up. Of course, there's also reinfection with the other muted virus, which needs to be also confirmed. At this point, we do not have a big variation, antigenic variation in the viruses. All this needs to be sorted out because this entire episode has been only about 4 months. So for compared to other diseases, we have been in great strides, but need more confirmation. Work needs to be done.
Thank you,
Thank you.
Deepta. Next.
This is Dr. Suresh again. I have another question, and this question is for Dr. Raman. And
Raman's not there, so it'll be Lena.
okay, why in some admitted patients after one negative test, which may become positive after 2 days after admission? Can you
Lena?
take us?
Oh, I can take that question if you want.
Yeah,
The
please.
negative test, yes. They are probably referring to the RT-PCR test, and PCR test can be negative because of the low viral level. I think many of the tests are, again, the sensitivity and the specificity needs to be done. Because of that, we bring the patient for that. Other reasons for negative test is improper transportation and improper collection, improper, what do you call that, your swabs and temperature maintenance. All of this can add on to the negative test. So if there is a negative test, high suspicion, clinical suspicion, bring them back, redo the test. Thank you.
Thank you, Deepta. The next question is to Dr. Anand. This is on ASTM test results. You have given an excellent slide. Do you have the results?
Yeah, we do. In fact, the ASTM results showed that for all the different methods that I mentioned, that is to say, autoclave, pasteurization, moist heat, UV, parasitic acid, and the other ones that we tested, they all actually passed the ASTM testing. That's why I was saying that the damage suffered with decontamination, to the extent that it occurred with some of the methods, it seemed to do more with fit than with filtration efficiency. We actually didn't find so far that any of the decontamination methods actually degraded filtration efficiency according to ASMT testing.
Okay.
But as I said, several of them cause problems with the fit itself, so that the mask, basically, if either of them fails, then you can't use it. So the fact that the fit testing failed means that, for example, Sterad, if used more than one cycle, you shouldn't use it because the fit of the mask won't be adequate.
Thank you, Dr. Anand. And the next question is to Dr. Suparna. Is it mandatory to take swabs from nasal and oropharyngeal? What's the most sensitive test for COVID?
The policy is to take both nasal and oropharyngeal. So nasopharyngeal and oropharyngeal double swabbing is what we're doing in the UK at the moment. The nasopharyngeal is the most sensitive.
Thank you. Thank you, Suparna. And the next question goes to Dr. Raman. If he's not there, Deepta can answer. The virus is known to mutate. Will this affect the RT-PCR results? Dr. Deepta, can you answer? Raman is not here, I guess.
I think your microbiologist who was from Apollo has explained it beautifully. We are now testing for 2 targets, which is the S targets and then the E target. At this point, the variation is minimal. We haven't detected big variations. It is yet to be seen whether we are going to see a mutated strain. And if that is so, then we will be having multiple other targets which will be added on to the test. So it is wait and see. It's easy to produce any of these targets because this virus can be analyzed very well, and the targets can be created very easily.
All right. So anyone can answer this question. What should be the optimum IgG titers in the potential plasma donors?
This is Anand Kumar. I'm working on some projects to develop hyperimmune globulin and similar products for patients in North America. But the short answer for that is nobody knows right now.
Right. Thank you. The next question is about masks, and there's a lot of CDC has recommended cloth masks. So this is about the cloth mask. Cloth mask for paramedics, is it safe to use? Can you take the masks home? We can't leave them in the hospital. I think certain hospitals don't have sterilization techniques. So any comments on that?
Yeah, so for Anand Kumar again, Anand Kumar, I've been in North America too long. Ideally, you keep the mask and have it decontaminated at the hospital. There are protocols for that. But if you have to take it home, what I would do is I would put it in a plastic or a paper bag. You want to be careful with it. And as I said, if you set it out in sunlight or even just out in the air, dry air for a few days, you will substantially decrease the viral load on the mask. You may not eliminate it completely even after a week, but it'll be substantially reduced to the point that it's probably not enough to be infectious. So you can do that. We have tested masks with high level exposure to ultraviolet light, which of course is the major issue in sunlight, and we do not find any deterioration of mask function, either in terms of filtration or in terms of fit. So I think you can do that at least a few times. Whether you can do it, 10 times, I don't know. For N95 masks, you should be aware that there are studies that show for N95 masks that you probably can't refit them to your face and get a good fit after about 3 to 5 cycles. So that's probably the maximum you can do anyway on a structural basis.
Thank you, Dr. Anand. So this is a question. JAMA has published a letter from Singapore yesterday. It shows very high risk of infection from fomites and air in the area where patients are isolated. The infectivity has not been covered in this webinar, but it is frightening to see the risks to medical and allied staff. Can anyone answer this question? What's the rate of infectivity in the fomites or in the air? Anyone?
Yeah, this is Anand Kumar again. I think that's reasonably well known because the virus persists. So, the areas where the patients are cared for or have been cared for, we always use ultraviolet lamps to try to sterilize that area, or otherwise wipe it down with fogging and that kind of thing. I don't know what's done in other parts of the world.
All right, thank you. This question is to Deepta. So the patient is admitted for 10 days in COVID ICU. PCR was negative on the 7th day and then becomes positive on the 10th day. So can you explain why this is happening? This is a second person asking the same question, but we need more light on that.
Yes, I think this is fairly a common scenario, as I had mentioned before, because of the amount of virus which is low or the improper collection, as I mentioned. And I think the clinical suspicion has to be high. And if all the other antimicrobial testing and antibody serology, all of them are negative, we do have to, at this point, we do have to take it as a COVID-19, continue the patient as it is and repeat the testing. Probably at this point, if the IgM-IgG combination is approved for acute testing, might help. I'm not sure about that. Thank you.
Yeah, one of my colleague has been tested negative and then positive and negative, but she's almost close to 28 days. So that's what she's worried about. So anyway, I think we all need to keep that quarantining thing for 28 days, looks like, not 14 days. The next question is to Dr. Raju. We are practicing routine COVID swab tests and CT chest before admitting cases to Ambani Hospital. What's your view, Dr. Raju?
Is if you do want to do, sorry, can you hear me?
Yes.
Yeah,
Okay.
yeah, we can.
So, the advice is not to do that. The advice is do a chest X-ray if you need to do anything, depending on the severity of the disease. If the disease is mild, then you don't even need to do a chest X-ray. If you're going to discharge the patient needs admission, then you do chest X-ray along with the PCR. And only if the chest X-ray is normal or it's not conclusive, then you proceed to do a CT chest. This is in cases where the patients are presenting. If the patient is admitted and obviously worsening respiratory status, then you do a CT chest to assess the disease anyway. From an admission point of view, you only do it in severe cases and only if the chest X-ray is either normal or equivocal.
This question is to Dr. Suparna. Can you unmute Dr. Suparna? There are a lot of PCR false positive, false negative, and so healthcare workers are worried like because of these. So what is your comment on that?
Sorry, so can I just clarify the question? So what is the role, what is the effect on PCR test negativity on healthcare workers? Is that what we're saying? Is that the question?
PCR false positives, false negatives, some test false positives, 30 false positive unless symptoms. So it's like vague question, but it's basically a question on false positives and false negatives.
Yeah.
So are we on that?
So I think the false positive PCR is a highly sensitive test, and it's very, very unusual to have false positive PCR testing. Unless there is a sampling error, or there is a contamination from a previous sample, previously, another person who's affected and so on. So that's more unfortunate, really. But the technological limitations of a PCR false negative is from, again, sampling. So they might not, it's not really a blood test. It'd be great if it was a blood test, then you could actually really control for this amount of antigen you're getting. But a sample is just as good as the sample is, so if it's not properly, if the swab is not taken properly, then the sample will test negative. So, so the false positives mostly in a very sensitive, highly sensitive testing like reverse transcriptase qualitative PCR. And the false positives only from sampling error in the sense that there is a previous contamination error and so on. False negative is from, again, sampling because it's not been done properly. I don't think we have heard cases where people have tested negative and then tested positive again, and then tested negative and then tested positive again. Clinically, however, I don't see hugely the benefit of retesting people if they're clinically better and are able to self-isolate after discharge. The only context where I think it would be necessary to retest somebody who has clinically resolved from their infection is if they have to come back to work and have a patient-facing job or a human-facing job. And in that situation, I think it will be important to ensure that the testing is negative. I don't know if this answers your question, but kind of sorry to ramble on a bit.
Yeah, that's the biggest issue for healthcare workers right now. Once they're positive, they are getting tested every week with PCR. So first week, second week, third week. End of third week, still they're positive, and the employer is like, come back to work. So that's the...
So we are not, in the UK, we are not even testing, unless the only situation where healthcare workers are being tested after returning from COVID infection is if they are working with severely immunocompromised patients. So, for instance, I work in a bone marrow transplant, aplastic anemia setting. So I, will have to have a repeat testing. But if somebody who's not working in that kind of setting will not need it. So this is a kind of, I suppose, a pragmatic, whether that's, I'm not suggesting for 1 minute that that's the right thing to do, because I strongly feel that quite a lot of healthcare professionals are being infected from people returning from work, fully clearing their virus. And, you know, there are reports of positive PCRs for up to 21, as you said. You know, it could be up to 60 days. We had one reported from Wuhan where they had 60 days of PCR positivity. Whether that actually equates to infectivity, who knows?
Wow, that's amazing to hear.
Thank you so much, Anupama and Suresh, for handling the Q&A so well, and like to thank the faculty. I'd like to thank Dr. Nandkumar Jairam, Dr. Sudhir, Dr. Gautam Bodhiwala, Dr. Ram Gopal Krishnan, Dr. Leena, Dr. Deepsa, Dr. Subarna, Dr. Raju. Thanks ever so much for joining. Thanks, Dr. Palu, and of course, Anupama and Suresh for helping us run this program and connect with colleagues across the world. And a big thank you to the team of Gapio and Dr. Tandon. We have gone way beyond we thought we would, but it's been a very fulfilling session. And the next one's going to be on the 7th of April, same time, 7 p.m. IST. And we're really going to dig deep into remdesivir and into plasma therapy and all the other chloroquine and so on and so forth. Talk about techniques in ventilation. So it's going to be a very clinical session. So please do join us and spread the word.